下面我想还是下面一个讲者是不是也是一个录播的节目啊？
但是Sachi他本人在线。Sachi本人在线。
那你就用英文邀请他一下吧。
因为我看下面也是一个录播的节目，我不知道他是用
他录好了，但是他在线，他在线讨论，然后录播录的讲。
那我们
邀请他一下。
Next is Sachi, Professor Sachi. His topic is transarterial multi plug flow control technique for embolization of Bavm. Welcome, Sachi.
Good afternoon, everybody. It's always a pleasure to talk in ocean, and I thank the organizers for their very kind invitation. Today, I'm going to talk on our transarterial multi-plug flow control technique for embolization of brain AVMs. Here is my disclosure. After we developed transarterial onyx injection technique, so-called slow repetitive reflux and push, with the growing experience, we have been realizing that an effective and safe nidal penetration is all about controlling to flow to or within nidus to facilitate the intranidal penetration with less early venous migration and less inadvertent nidus to arterial reflux. In order to do that, we have developed a multi-plug nidal flow control technique, creating a closed flow controlled system around the nidus. You see an example of a small right parietal AVM where we placed 3 double lumen balloons in the major pedicles feeding the AVM. And after seeing the territory of each pedicle with consecutive angiographies, we started injection and controlled the flow, and we were able to occlude the AVM. This technique provides a real control during nidal penetration compared to the other techniques because washout from other pedicles slows down or prevents it. This technique lessens not only the amount migrating to venous side, but also amount of reflux on microcatheter. And this let us occlude the veins and feeding arteries at the closest proximity to the nidus with substantially reduced risk of arterial ischemia and venous compromise. We always ask for an MRI after the treatment to check the brain parenchyma. This workflow of the technique is very similar to microsurgical management, where you turn around, control the feeders, take down the nidus, and occlude the veins. First, flow control strategy is determined, and for the angiography is a great tool for that, so that we can analyze the feeders, see their exact courses, the starting point of venous outlets, nidal morphology is well seen. And after the strategy is defined, we determine whether we will use detachable catheters or double lumen balloons according to the pedicle anatomy, including size, tortuosity, distality, flow rate, presence of unpassaged branches, etc. And then we select the access system accordingly. In this left posterior temporal AVM, with the help of 4D, we selected the major MCA temporal pedicle and 2 smaller size, more tortuous pedicles coming from PCA. And based on that information, we placed 2 Apollos in the pedicles coming from the PCA, and 1 Septerex C is placed in the MCA temporal pedicle. And then we find the working projection where we see the distal segment of each catheter, at least in 1 plane. And then we do an angiography, sequential angiography, to appreciate the territory fed by each pedicle. And then we start our injection simultaneously from all catheters. Because balloon is already occluding the flow, it immediately goes into the nidus, whereas in the detachable one, it starts to reflux to perform a plug. This one shows some infiltration, and then stop and inject again. As we are controlling the flow, the embolic agent is not going to the vein, but filling the nidus. There's some reflux, so we stop in this one and start again. So after the initiation, each catheter goes according to its pace. And we never rely on the control angiography, even though we see apparently a complete occlusion. For example, in that particular patient, we continued another 42 minutes of injection, and you see small pieces of AVM is filling. Despite that, we do not see much in the control angiography. So patience is the key, not only in starting, but also in ending. And these are the control angio simultaneously simultaneously injected left ICA and left vertebral artery. Onyx cast is exclusively in the nidus with the occlusion of the veins in the vicinity of the nidus. And you see the postoperative MRI imaging. Another temporal AVM, who the patient had a previous bleeding, and multi-plug flow control technique offers single stage cure if we can control all feeders in grade 1 and 2, and also selected grade 3s and 4s. For the angiography is very, very helpful in making the flow control strategy plan. For example, in this one, there is a clear stenosis of the main draining vein. So it's very important to control the flow to the veins, especially at the beginning of our injection. We don't want to send too much material to this major vein at the beginning. And we selected 2 pedicles of MCA and 2 pedicles from PCA, where we placed 1 double balloon catheter and 1 Apollo in the MCA pedicles and 2 Apollos in the PCA pedicles. And we were able to, we were able to obtain this cast. The cast is very compact and limited to confined in the nidus. The vein is occluded in the very vicinity, so we didn't send too much material to the arterial pedicle by the reflux or into the vein too distally. So it increases the safety by preventing both the arterial ischemia and also the venous compromise. 1-year control angiography, nice cast, stable occlusion. This is a patient treated during the live WLNC in Barcelona, high flow grade 4 AVM, and we put a balloon catheter in the PCA pedicle, relatively straight course, and 3 Apollos in the MCA pedicles. Please don't get intimidated with these images, but it also shows that it may be sometimes very complex. That's why it's a team approach. And because one person cannot follow all catheter tips at the same time in 2 planes. So it's very important to work as a team with this technique. And with a full control of the flow, we were able to achieve such a cast. And this is the 2 years control angio and 1-year MRI on this patient. Very efficient technique. In such critical location AVMs where the critical artery is to be saved, we don't want reflux. This technique is very important. This is an hippocampal AVM with a big venous pouch surrounded by edema. And because anterior choroidal artery is very crucial to be kept patent till a certain point of safety, we placed 3 microcatheters to control the flow. The 3 Apollo, one is from the temporal branch of MCA, another one from the PCA temporal branch, and the third one is through the anterior choroidal artery. The aim is not only infiltrating from this microcatheter, but more importantly, to prevent any uncontrolled reflux so that we would not end up in morbidity. And we were able to cure this AVM with no harm except for this tiny dot, single dot. Otherwise, the parenchyma is intact and the patient is normal neurologically. And the 2 years control angiography and 2-year control MRI showing complete occlusion and thrombosed AVM. Off-flow control may not be provided during simultaneous injection in some cases. After determining the flow controls strategy, it can be done with just occlusion of a critical feeder proximally so that the nidus part that critical feeder supplies can be hit with flow-controlled injection, also without an inadvertent reflux to that feeder. In this high-flow left parietal AVM with deep venous drainage. And the 4D, according to 4D, the ACA pedicle is selected and 2 MCA pedicles, as well as the posterior choroidal branch, but it was not possible to catheterize this posterior choroidal artery with a detachable catheter. So before starting our simultaneous injection, we occlude this posterior choroidal artery proximally so that there will be full flow control and no uncontrolled inadvertent reflux. And then two mini septors, one from ACA, one from MCA, and the third microcatheter was from MCA and Apollo. And we started injection, and we were able to occlude this AVM. And you see the post-operative angiography. And the control MRI showed significant edema around the occluded AVM, the vasogenic edema, no cytotoxic edema to indicate any arterial ischemia. The patient has a seizure due to that. Post-operative 6-week control MRI reveals complete resolution of the perineidal edema, no harm to the parenchyma otherwise, and the patient is neurologically intact, 1-year control angiography. And another example, not always we can finish an AVM in a single session. This patient had previous partial embolization and followed by a gamma knife 10 years ago, but obviously failed. It was an outside case, and the patient had 2 times intraventricular bleeding, referred to us for endovascular treatment. And we decided on a staged curative multi-plaque embolization after 4D evaluation. In the first session, we plan to do PCA feeders, catheterization, and embolize only these from these pedicles to eliminate the intranidal aneurysm and to decrease the number of feeders to prepare the AVM for final curative multi-plaque treatment. You see the intranidal aneurysms. They are eliminated by this preliminary session, first session of embolization. And this was the this was after first session, relatively compact nidus remaining. The major part is remaining for the second session. In the final stage, 4 Apollos, 1 from left ACA, 3 from MCA pedicles, and a mini septor from the PCA pedicle. In order to do that, we needed triple accesses, right radial, bifemoral, and an Apollo was placed from right ICA to the left ACA pedicle, and then from the 7 French sheath, 3 Apollos were placed in the 3 pedicles from MCA, and a mini septor from the PCA pedicle. From this pedicle, we plan to inject, we injected fill, and from the other pedicles, we injected onyx. Mini septor is prone to premature occlusion, catheter occlusion. That's why we preferred fill. It also makes us realize that fill is coming from vertebral artery because the density is different. And eventually we were able to occlude totally this AVM, grade 4 AVM. And you see the control MRI on this patient. So as a sum up, This summarizes our experience with multi-plug flow control technique. We treated 159 AVMs with multi-plug flow control technique with the intention to cure. Most of them are grade 1, 2, and 3s, and we were able to have complete closure in all grade 1, 2, and 3s with acceptable mortality and morbidity. Overall complete closure was 92%. One patient was operated for a post-operative bleeding, decompressive surgery, but eventually MRS won in 3 months control. So conclusion is multi-plug neither flow control technique created a substantial change in the AVM management, providing much safer, efficient, and more controllable curative management, but it certainly requires a very good quality DSA system so that we can follow all the catheters, and of course, team approach. It's not a one-man business, not only during the planning of the treatment, but also during the simultaneous multi-plug liquid injections. I thank you for your interest, and we'll take the questions at the end, I believe. Thank you. And I invite you to WNNC this April.
Okay. Hi, Professor Shati. Thank you for your excellent presentation. And it is very high. And it is very remarkable that the multiple plug lighters flow control technique greatly increased their embolization rate, totally embolization rate for their AVM, especially for their high grade, that is Spetlamatin 3 AVMs. So I have some questions, and one is that I noticed that you have showed some large AVMs, that is, and the size of the AVM is larger than 3, even 6 millimeter, and you are choose to embolize it in one stage. So do you are you worry about the hyperperfusion syndrome for these patients? This is the one question. And the second question is, if we do not use this multiple plug technique, and then when we are trying to embolize the AVM totally via one pedicle use pressure coconut technique. But before that, we will choose to embolize some pedicles. Do you prefer to only embolize the feeding artery itself, or you will embolize some of the some part of the niders? Thank you.
Thank you. I couldn't really understand the last question, but let me start with the first one and the second one. Regarding hyperperfusion, well, the big AVMs are usually having too many pedicles that we cannot embolize as a multi-plug in one session. In those ones, we do stage. But if the pedicle number is less enough, I would say, to handle in one session, we prefer to go and embolize in one session rather than staging, because we worry about if, giving little some, it doesn't really help. On the other hand, if we attack at the same time from all the pedicles, controlling the flow like surgery, so that we can go till the end and we offer cure in one session. This, in our experience, this decreases the risk of post-operative bleeding because you control the flow. Otherwise, sometimes in stage therapy, despite that, you see that you do not compromise the venous flow and do partial embolization, you can still have post-operative bleeding. So we worry about that more. But we stage AVMs when there are too many pedicles to handle in one session because of the access. I mean, you cannot put 8 catheters. So then we stage horseshoe. So what was the third question? And would you please repeat it again, the last question?
Okay, sorry, and I will repeat it. Yeah, just when you are doing the stage session, stage embolization, during the when you are trying to embolize the pedicles, do you prefer to just embolize the pedicle, the artery itself, or you will prefer to embolize some of the lighters? Will you?
Yeah. Now I got it. Well, if possible, we prefer to embolize the nidus as well. We do not limit it to the feeder occlusion. We don't like feeder occlusion. The feeder occlusion is only for the purpose of, for example, if we cannot advance too distal in that particular pedicle, at least in order to avoid reflux through that pedicle to the critical artery, we occlude that as a feeder occlusion. So, and during the multiplug technique, if that pedicle we are proximal and we are not expecting to infiltrate the nidus, then we do not want to be bothered by that pedicle, so we occlude as a feeder occlusion, and then do multiplug from the other ones, so that we can at least lessen the number of pedicles and lessen the flow coming from that pedicle, and of course prevent the reflux as well. So that is the idea. So but the principle is, of course, hitting the nidus part as well. It's just as an exceptional application.
But in our experience, that when we are trying to do the staged embolization, especially for some large ones, or just larger than 3 millimeter, and the AVM. Sometimes when we are trying to embolize the one pedicle, and when we are when we let the onyx infiltrate into some of the nidus, then we are worried about. Sometimes we may separate the nidus into diffused ones, and then it may be prevent us to totally embolize the IVM in the last stage. Is it right? Well,
actually, in the staged plan, we usually try to finish or hit the peripheric part, which may cause problems towards the ends, because they, as you said, they remain remote and separate from the main AVM nidus. Usually, in this, if we are planning to do in a staged way, we leave the main part to the last. We first try to finish the the remote part or the peripheric part, so that we can hit the main part in the final stage. Our main shot is the last final stage, actually. So the first stage is to reduce the number of the feeders and to make it compact, to decrease it starting from periphery to central. So we leave the central to the last.
Okay. Thank
you. I don't know if this is the answer of your question.
It makes sense. Thank you.
Thank you.
And thank you for getting online with us. Thank you.
Thank you so much. Thank you for the invitation and congratulations for your meeting. Thanks.